Welcome everyone and good morning. Today we have Dr. Richard Rawson who will be giving us an update on methamphetamine. If you have questions for Dr. Rawson, make sure to use the Q&A button to submit it at any time, either during the presentation or during the Q&A itself. And don't forget to check your email after the presentation ends to fill out the survey for CME credit. And now I'll ask Dr. Larissa Mooney to introduce the morning speaker.
Good morning, everyone. It is my great pleasure to introduce our Grand Round speaker today, Dr. Richard Rawson, whose talk is titled Methamphetamine 2020, New Risks and Current Treatments. Dr. Rawson is Professor Emeritus at the UCLA Department of Psychiatry and a research professor at the Vermont Center for Behavior and Health at the University of Vermont. Dr. Rawson is the former co-director of the UCLA Integrated Substance Abuse Programs, also known as ISAP, and has been my longstanding mentor in the field of addiction. He in fact opened the door for me at UCLA back in 2007, so it is especially meaningful for me to be introducing him today. Dr. Rawson has conducted numerous clinical trials on pharmacological and behavioral treatment interventions for individuals with stimulant use disorder, including cocaine and methamphetamine. He has led addiction research and training projects for the United Nations, the World Health Organization, and the US State Department, exporting science-based knowledge to many parts of the world. Welcome, Dr. Rawson.
Thank you. It is a great honor to be introduced by you, Larissa. I appreciate it. Okay, are we good? You have my slides. Yeah, I was thinking back, I think I did Grand Rounds, may have been on methamphetamine or cocaine in, I think, 1995. The major differences were, of course, I was doing it in person. I had less forehead, and I was wearing shoes at the time. So there's a few differences between now and my earlier Grand Rounds. Just make this note, in the field of substance use disorder, it's been about a 50-year journey going from the early work in the 60s to what we're doing today. And our terminology has changed. We started, anyway, I'm going to try to stick with person-first language, which individuals who use cocaine or methamphetamine, rather than saying things like addict or cocaine user. But I do want to just ask for your indulgence that I'm an old dog and this new terminology sometimes gets tangled up in my mouth, so I'm sorry about that. Okay, we're going to talk about methamphetamine. This was recently seized about 5 months ago by the DEA in Rhode Island. It comes in now in kilo bags or 2 kilo bags. It's all crystal methamphetamine, and the vast majority of methamphetamine now comes in from Mexico. Just a very short history. UCLA's work in the area of methamphetamine started in the late 80s and early 90s. California, well, the first epidemic, quote unquote, started in San Diego, San Bernardino, and San Francisco pretty much in the 80s, gradually spread throughout California and then across the Western United States up through about the early 2000s, and then continued to spread into the South. And it was mainly homemade methamphetamine. If you watch Breaking Bad, they actually did a pretty good job of describing the home labs and what they look like, going from campers and people's kitchens to fairly sophisticated labs. One of the big issues at the time when we used to do trainings around methamphetamine was for narcotics squads about how to make sure they weren't going to get poisoned by when they took down the labs. In 2005, Congress passed the Combat Methamphetamine Act, And the main thing it did was to severely restrict the availability of pseudoephedrine, which was the primary ingredient. And so you used to be able to buy literally cases of pseudoephedrine. Now you can buy 1 or 2 packs in bubble packages. And so it's really been restricted how much you can get. And that actually worked. And there was lots of people from DEA and Congress slapping themselves on the back that they had eliminated the methamphetamine epidemic. Now you would see people still running around to 15 pharmacies buying their 2 packs per pharmacy, which was a practice called smurfing, and then making their own meth. But it really reduced by a very large fold the number of labs and the amount of methamphetamine being manufactured domestically, and no more lab explosions. And like I say, we saw people saying, well, that's it, we've done away with the meth problem. And this shows you the domestic labs. They were at a peak in about 2003, and then we saw the real sharp reduction, a slight rebound, and then they've continued. When they rebounded and started producing domestic meth again, they found that it was no longer profitable because there was so much methamphetamine coming in across the border that the cartels took over the market. And the mom and pop labs, or as we lovingly referred to them, the Beavis and Butthead labs, were no longer worth doing. You could buy it at your local, outside your local liquor store, very inexpensively. So that was the earlier methamphetamine problem, and starting at about 2007, 2008, we started to see the numbers go back up again as the drug came across the border. Now, what we're currently, one of my take-home points today is that the meth that we saw in the 90s and early 2000s is very different than the meth we see now in 2 ways. One, the manufacturing method is different. They use a method called P2P, which produces a much more potent and lethal, potentially lethal form of methamphetamine. So we're seeing a lot more medical, psychiatric, and overdose related to meth use than we used to. In the earlier period, when we would get people in treatment, we would do our best, but if they dropped out of treatment, they dropped out of treatment, and they would eventually come back in, and it was sort of, that's the process that you go through. Well, now when they drop out of treatment, they often get dead. And so this more potent form of methamphetamine is important to keep in mind. And the amounts coming in are huge. The DEA estimates 10 to 20 times the amount coming in a decade ago. The other big change is that much of the methamphetamine and cocaine, for that matter, in the United States now contains fentanyl. The last data I saw from the state of Washington were that approximately 80% of the samples in the state of Washington had fentanyl in them. I believe California is about 50%, but that's just a guess. But you now have this combined product. It's no longer where the user mixes them. It's mixed in at the source. And so the cartels have developed relationship with the Chinese fentanyl suppliers, one of which was in Wuhan. And for a while, when the Wuhan epidemic flared up, there was a shortage of fentanyl for a while, and there was no fentanyl in the methamphetamine. But now everything is back to the way it was, and we're seeing increasing amounts of fentanyl in the stimulants. There is a new development in Wisconsin, Illinois, Missouri. They've seen this new drug, which I'm not sure I'm pronouncing correctly, isotonitazine, commonly referred to as ISO, which apparently is an opioid that is equally potent as fentanyl. Excuse me a second, I forgot to plug in my internet cord. Sorry. So to get you a little bit, again, over the historical perspective of the current drug situation in the United States, this starts in 20 years. So this is what you heard and read about in the news over the last 20 years about the emerging opioid epidemic, with prescription opioids driving the epidemic until about 2010. Then the number of, this is overdose deaths, by the way. And overdose deaths have really become the most important metric that we look at for obvious reasons. I mean, they're overdose deaths, but we didn't really do this before with, we had all sorts of different epidemiologic measures, but it's been clear that for policymakers, overdose deaths are really the metric we need to be most attuned to. So here was the prescription epidemic phase. Beginning at about 2010, as restrictions started on prescribing, as there were all the AMA, Medical Association cautions about overprescribing pain medication. You saw a somewhat dip in the amount of people dying from prescription overdose deaths, but you see more than made up for by the number of heroin overdose deaths. Beginning in about 2014, you see this. This is when fentanyl made its appearance on the streets in the US. Happened very fast from about 2013 through 2016 is when we see that spike, and that line has continued to go up. It's the total number of overdose deaths now is well over 70,000 in the United States per year. So this is what we call the three phases of the opioid crisis. And then we saw this, which is about the same time as fentanyl numbers increased. We started seeing a rapid increase in stimulant related deaths, cocaine and methamphetamine. And I'll talk a little bit more about that now, but currently the stimulants are the second number drug category to be associated with overdose death. Now, the fentanyl being added in makes a big difference because these are lethal doses of heroin, fentanyl, and carfentanil. And as you can see, it doesn't take much fentanyl to produce an overdose death. And it takes about 100 times less than that for carfentanil to produce an overdose. Carfentanil has been seen in Ohio and Tennessee and some outbreaks, but it doesn't seem to be likely that this will be a drug that the cartels will be involved in because it kills all their customers too rapidly. They don't really want a drug that's so potent that everybody dies. Not a good business model. So, but fentanyl is certainly, when I used to be doing opioid treatment back in the 80s, and a prescription or somebody would do a pharmacy burglary and get a fentanyl and it would be on the street. It was really considered an emergency. The police would, put up all kinds of information about the dangers of fentanyl. Now it's sort of routine. It's now part of the landscape, and it's right now the primary reason that we're seeing so many deaths from overdose. This is a graph from a CDC report, and I think this is really important. It's a little bit dated, it's 2017, but the dark blue bars are the number of deaths from cocaine, and the light blue bars are those related to methamphetamine. If you notice non-Hispanic whites, it's about equivalent. You see about the same number of deaths from cocaine and from methamphetamine. Among non-Hispanic American Indian, American natives, we have the most severe overdose death situation related to methamphetamine. On the communities in the Native American communities, methamphetamine for the last 20 years has been consistently a killer, and as fentanyl has come into it, it's increased its lethality. I think pay attention though to the second set of bars. One of the things I've become particularly puzzled by and unsettled by is the fact that in an average week, I now get 3 to 5 inquiries about doing talks or consultations or helping states set up treatment or And it's all about methamphetamine. It's all about, I got a call last Friday from a person in the governor's office from New Jersey saying they thought that they really needed to respond to the meth problems in South Jersey, that they were starting to see a lot of them. They wanted to set up special clinics using evidence-based practices. And I said, that's great. I said, but by the way, have you checked, what about your inner city clinics in Newark and Camden and places like that? Are they using evidence-based treatment? Because the number of people in the African-American community dying from cocaine overdose, as you can see in this slide, is roughly equivalent to what we're seeing with other groups with methamphetamine. In the African-American community, it's starting to change slightly, in California at least, but cocaine has been the drug, the stimulant of choice. And as you'll see, the number of deaths from methamphetamine and cocaine are almost equivalent in the United States now. So it's not as though we have one stimulant problem. We have one stimulant problem in one set of places and amongst one set of populations, but we have another one within predominantly in the African-American community, which is getting very little attention as far as I can tell. I have not received one inquiry about, can I help some community that has African-American community set up evidence-based treatment? It's all been around methamphetamine and predominantly in white and Hispanic communities. These are data from CDC from 2019. Now these are deaths from deaths per 100,000. The blue line, the solid blue line is in both graphs is the total number of deaths associated with methamphetamine. In the left-hand panel, you see the bottom line, the dashed line at the bottom is the rate of deaths that had fentanyl involved with methamphetamine. The dotted line is any opioids at all. And as you can see, they're going up in parallel. But if you look in the right-hand side, the same blue line, same solid blue line for total, but you also see there increases in deaths without any opioids. With methamphetamine, the meth itself is lethal with or without fentanyl. Now it's a different picture with cocaine. With cocaine, almost all the fatalities, or the majority of them, are fentanyl deaths. Cocaine deaths by themselves is relatively rare. So there is a difference in terms of the picture of overdose deaths among those two groups. As you can see, just in general, you're going to see more meth users in all of the, individuals who use meth in all of the medical psychiatric facilities. As we go forward, you're going to see increasing numbers and increasing severity. For those of you who are providing treatment to individuals with opioid use disorder, the bane of your existence, if it isn't already, will be the fact that folks on buprenorphine often will start experimenting with or going back to whatever the history they have to stimulants. It was a big problem in the 90s, and I'll show you some data on that, where the patients we had on methadone for opioid use disorder, 70–80% of them were using cocaine, and it really was disrupting their treatment progress, and they would start injecting again, and you would start getting all kinds of crime involved. So when people on medication for opioid use disorder start using stimulants, it's not a good thing. And my second take-home message is, and I don't think I need really to cover it with this audience, but don't kick them out of treatment. That's the one thing you don't want to do, is say, well, you're using too much methamphetamine and you won't stop, so we're going to kick you out of treatment. There again, the lethality of the drugs on the street are such that you're really making, that's a very risky thing to do. And when you kick people out of treatment for addiction, they don't get better spontaneously. They get worse, and in this case, they often get dead. This is a study from published earlier this year from the state of Washington. 700 or about 800 patients entered into treatment onto buprenorphine. About 2/3 did not use methamphetamine at the time of admission, together with their opioid. About 1/3 of them did use methamphetamine at the time of their admission. And these are the retention curves. The top retention curve is, I mean, if you look at this out to about 800 days, you still have about 50% of the patients on buprenorphine, which is really excellent. However, if they were also using methamphetamine, you see a much greater drop off and less problem with retention. So one of our issues, some of those probably when this study was done, were people who dropped out of treatment because they were kicked out of treatment. But even if you don't kick them out of treatment, the retention with that population is much more challenging. A lot of new information on methamphetamine. Back during the earlier epidemic, NIDA started to put together a fairly robust program of research around methamphetamine. It somewhat got de-emphasized during the opioid crisis years, 2005 through 2015, but there's still been a lot of good new information. Martin Paulus and colleagues from UC San Diego just published a review in JAMA Psychiatry, and I'm not going to go through it all, but just a few of the high points. I'm not going to talk about neurotoxicity because I think Edie London is on this, and I would be embarrassed to use my Tinker Toy model of neurotoxicity with Edie on the presentation. And also Andy Dean is maybe on the presentation. Andy's done some great work around cognition and methamphetamine. He did some of the earlier work. That work has been expanded and others have gotten involved in it. No question that individuals who use methamphetamine chronically have substantial damage done to their cognitive abilities that doesn't go away right away. Some of it gets better pretty quickly, but even after prolonged abstinence, you still see learning efficiency and comprehension, visuospatial processing, and processing and psychomotor speed. Those are all still persistently affected. A recent analysis, a meta-analysis of the relationship between methamphetamine and violence. There have been, in this case, there were 28 studies they reviewed. And amphetamine use, individuals who use amphetamines tended to show up in violent episodes with a twofold increase in over normal populations and other patients with other substance use disorders. And typically the violence comes when they're psychotic, when they've taken methamphetamine to the point where they generated psychosis. That's when their violence is most likely to happen. So certainly as people deal with meth users in the individuals who use methamphetamine in the emergency department or in medical settings, and they're presenting with psychosis, they are people who need to be carefully managed in clinics. New data, some of this data on cardiovascular disease was generated in Hawaii, because in Hawaii, they first saw the smoking of methamphetamine in large amounts. And by the mid-decade of the 2010, they were starting to see a lot of cardiovascular problems among methamphetamine using individuals. And strokes are a particular issue, and you see other severe cardiovascular issues as well. This is a review study of strokes among young adults who use methamphetamine. 77 articles. They're mainly case studies where they documented the types of strokes. They found that ischemic strokes were primarily associated with inhalation, and hemorrhagic strokes were associated with oral or injection route of administration. Injection in particular, if I forget to say this, how route of administration is real important, and with injection, everything is worse. Medical issues, psychiatric issues, risk of infectious disease, and treatment prognosis, all of those things are worse. They need a higher level of care if they're injectors. And this is just some data on what to be aware of in terms of identifying stroke among this population. There's just a review of stimulant use in pregnancy with, this was published in last year, 2019, is last year 2019? Yeah, last year. Meta-analysis of 31 studies, cocaine and meth users. Cocaine was associated, the pregnancies were characterized by increased risk of preterm delivery, low birth weight, small for gestational age, earlier gestational age of delivery, and reduced birth weight. For the 8 methamphetamine studies, methamphetamine during pregnancy was associated with earlier gestational age at delivery, lower birth weight, and smaller head circumference. Infants with prenatal exposure to methamphetamine exhibited a more severe withdrawal syndrome with jitteriness, drowsiness, and respiratory distress. Both cocaine and methamphetamine are excreted in breast milk, and if the mother is currently continuing to use, breastfeeding is contraindicated. There have been some studies now on kids that were prenatally exposed to methamphetamine. Chris DeRoff in University of Hawaii led one of these studies. At 1 month post-delivery, the methamphetamine exposed mothers did not have, or a third of them didn't have custody, 2% of the unexposed. At 3 years of age, heavy prenatal meth was associated with anxiety and depression and attention problems among the children. And at 7.5 years, the children had poorer cognitive function. And so that there's a good deal of work going on that right now. And of course, as we'll talk about, we have no buprenorphine. And so to try to get these pregnant women into treatment, the way we have been able to do quite effectively with opioid use disorder, not so much with methamphetamine because we don't have the same potent effective medication. Nora Volkoff earlier, I don't know, a couple months ago, just published this article on COVID-19 and the addiction epidemics in general. Her main point was people who use drugs are at greater risk for having a severe COVID reaction. The fatality rate of 6.3 for people with chronic respiratory disease, among 2.3 death rate overall. And when people are smoking, vaping, or using opioids or other drugs by inhalation, you get reduced respiratory functioning. Opioid use causes hypoxemia. Methamphetamine use causes direct pulmonary damage if they're smoking it or if they're injecting it. And of course, with the current social distancing, the value of Narcan for reducing overdoses has been more restricted because people are more using by themselves. And so they don't have a friend there who can give them an injection of Narcan or call the ambulance. And so the death rate, the last data I've seen, which was just from a couple of weeks ago, is roughly a 20% increase in overdose deaths of all forms related to the period of time, the COVID period. So it really has been an increased challenge for individuals with substance use disorder as well as treatment groups. Clinical challenges. The first one is one I didn't have on my old slides because we didn't particularly worry about meth users overdosing and dying, but now we do. And now that's an overriding condition. I do a lot of training with counselors in treatment programs around the country, and many of them are sort of the old style counselor types who are not particularly harm reduction oriented. They tend to be pretty abstinence or nothing, and trying to explain why this overdose death issue has changed the ballpark is really one of the things I think is most challenging and important, because this is a new aspect of treating individuals with stimulant use disorder. Unlike opioid addicted individuals, the stimulant users tend to have a less of a understanding of their addiction. Individuals who use meth and cocaine tend to think that individuals who use opioids are, they're people who are really addicted, whereas they can take their stimulants and stop occasionally, and they view that if they're able to stop, then they're probably not addicted. So if they don't view themselves as having an addiction, they're pretty ambivalent about the need to stop using. And so when you're getting this patient population into treatment, you have people who have a very high level of ambivalence about A, whether they need treatment, B, whether they have a problem. And so it's a challenge. That's a challenging issue to engage them in treatment. Because of the effect of the drug on the brain, you see impulsivity. I'm sure some of them had impulsivity and poor judgment before they used methamphetamine, but it gets worse. Cognitive impairment and poor memory, we mentioned. Anhedonia is kind of the hallmark of stimulant dependence during the first 4 to 6 months. Anhedonia can be a major issue in relapse. Just nothing feels good. And we know why that is. I mean, the issue, we'll talk a tiny bit about the role of dopamine and the recovery of the brain after cessation of stimulants, but this anhedonia goes on a while. People engaged with methamphetamine typically go through periods of hypersexuality, and then when they stop their use, they often go through hyposexuality, psychosis we mentioned. Whereas with individuals with opioid use disorder, kind of the central dynamic of their addiction is I'm afraid I'm going to go into withdrawal and I'll do anything to avoid withdrawal. That becomes the driving sort of force of the opioid seeking behavior. Not true with stimulants for the most part. With stimulants, you have much bigger role for Pavlovian cueing, triggering. They're, cruising along, doing relatively well. All of a sudden they come in contact with some stimuli previously associated with their use, and wham, they've relapsed. Money is a classic, and it's been a major issue. Elevated rates of psychiatric comorbidity, and of course, the major thing we focus our treatment effort on is how to keep them in treatment. These are some of the particular groups that have important challenges. Those who inject, as I mentioned, those who are daily users. In a lot of the studies we've looked at, you get a very different response from people who use daily, regardless of route of administration, and everybody else. I mean, daily meaning 28, 29, 30 days in the previous 30. So those high frequency users and the individuals who inject, they come in with a much more difficult challenge in their stopping and in their avoiding relapse. We see high rates of meth use with women, and many of them come into treatment with significant issues around physical or sexual abuse, both current as well as historical. The population of homeless and chronically mentally ill patients are challenging. I'm doing a consultation with the city of Portland about working with this population as being their target population. Heavy meth use, hard to get them into treatment, hard to make any progress. Men who have sex with men, I'll talk more about that in a bit. Steve Shoptaw and Kathy Reback at UCLA have led much of the work in this topic over the last 30 years and have done some great work and have really focused on how to provide treatment for this population that is patient-centered and is on point. Individuals who use stimulants under 21 have their own set of challenges, and of course, individuals in medication treatment for opioid use disorder. That's also a real priority group. I just wanted to bring this up. This just came out in the latest drug and alcohol dependence. They talked with 600, almost 600 people in a harm reduction program in Washington. 443 were primary opioids was their primary drug, 140 methamphetamine. When they asked them about their interest in stopping, well, 82% of those people who used opioids said they really felt they wanted to stop and that they were hoping to get into treatment. About half of that for individuals who use methamphetamine. This ambivalence and this lack of interest in treatment, compounded by the fact that we don't have an effective medication, makes this population much more challenging to get into treatment and to keep in treatment. Clinical interventions. Harm reduction strategies or low barrier strategies. This again was something that Steve and Kathy did a lot with here in Los Angeles. And there's now a much greater appreciation for the fact that for individuals with stimulant use disorder, you can't present it as an either or, that they have to either get abstinent and be in full recovery with no relapses, or not be in service. There needs to be an additional set of services, certainly syringe exchange, providing them with information about fentanyl, possibly giving them naloxone. Meth user individuals who use meth just as a routine thing, and then some other things just about their general hygiene and their because use of methamphetamine produces pretty damaging set of effects on the body. Okay, treatment. This is pretty simple. There have been 5 or 6 meta-analyses or systematic reviews done in just the last few years. This one was done in 2018 by a group from Oxford who focused on doing meta-analyses of everything. This happens to be the one they did on cocaine and amphetamine addiction. They reviewed 50 clinical studies with about 7,000 participants with 12 different psychosocial interventions for cocaine or amphetamine. And their conclusion was the combination of contingency management and community reinforcement approach was the most efficacious and most acceptable treatment, both in the short and the long term. Very definite, very unambiguous conclusion. This was from a Corcoran collaboration that's now about 10 years old, same topic. They looked, their conclusion, this was 27 randomized studies. The comparison between different types of behavioral interventions showed results in favor of treatments with some form of contingency management in respect to reducing dropouts and lowering cocaine use. This was a review last year by Mike Farrell. Steve Shoptaw was one of the authors on this paper. I think Steve was the only non-Australian, but it was done out of Australia. Psychosocial interventions other than contingency management have weak and non-specific effects. And so they didn't really see anything other than contingency management. And finally, this was in drug and alcohol dependence about 2 months ago. 44 studies reviewed. Conclusions. While contingency management interventions showed the strongest evidence, they also said there was some effect of tailored CBT and CBT with contingency management. So there's very little question in the data that we have that contingency management is by far the most robust intervention we have. Some evidence for CBT and community reinforcement approach, some evidence for motivational interviewing, and some of the work we did at UCLA has evidence of support for physical exercise. I just want to close with a quick snapshot of some of the work in this topic that's been done at UCLA over the last years. Of course, Dr. London and her colleagues have been leading the way. I just wanted to mention this study. This came out of our exercise study, the effects of exercise training on striatodopamine D2, D3 receptors in meth users during behavioral treatment. We're going to have to change that title to individuals who use methamphetamine. But anyway, Chelsea Robertson led this paper, and a lot of interesting data. But basically, in our study, the exercise study, we had about 75 individuals per group. Half of them got an 8-week, 3-time-a-week exercise program. The other half got an education information session control. They were imaged at baseline and at 8 weeks. And you got significant differences. It improves in both groups, but the improvement was greater in the 3 areas of the brain for the exercise training group. And Dr. London and Dr. Mooney are both following this up right now. In addition to those brain findings, though, we also got, I think we published 10 papers out of this project. Exercise was associated with improved physical conditioning, reduced weight gain, improved cardiovascular functioning, is increased heart rate variability, reduces symptoms of anxiety and depression, reduces craving. We're just doing a paper on craving right now. Enhances recovery of the dopamine system, as I mentioned, and reduces relapse. People did this project while they were in residential treatment, and when they discharged out of treatment, those with exercise relapsed at a lower rate. And this is some of the work that Dr. London and Larissa Mooney are continuing to do now, and some of the questions they're addressing in their current research. As I mentioned, we did some work with contingency management. This was one of the early studies that actually was run during the 1990s, where we compared contingency management with CBT as a treatment to address the stimulant use of people who are on methadone maintenance. So again, this is going back to the issue of when you have patients on medication for opioid use disorder, often stimulant use can become a very significant clinical problem. And at the time that this was going on, about 70% of the patients in the clinic we were operating in were using cocaine on top of their medication. Randomized clinical trial, people were assigned into one of 4 conditions. They got over a 16-week period, they got contingency management for drug-free or stimulant-free urine samples, or they got 3-time-a-week cognitive behavioral therapy for their stimulant use, or they got the 2 together, or they got standard methadone treatment and they didn't get any special care. And I'll show you, this is one of the basic slides. This is the number of stimulant-free urinalysis tests during the course of treatment. For those on methadone maintenance, less than a quarter of 25% of their samples were stimulant-free. For those on cognitive behavioral therapy, it was almost 20 samples, but still well less than half. The 2 groups that were on contingency management, both contingency management alone, contingency management plus CBT, showed significantly better performance than the other 2 groups. Now, as I mentioned, in the men who have sex with men community, methamphetamine has been a real priority issue, because they're in all populations, methamphetamine is often associated with sexual behavior, but with this population, increased unprotected sexual behavior is a real driver of HIV transmission. And for that population, meth enhances sexual functioning and does all these wonderful things. And you see higher rates among that population than in other populations. Steve Shoptaw and Kathy Reback, this is an old study, and I won't go into the detail, but they did studies similar to the one I described in the methadone treatment program. Standard care, CBT, contingency management. They found that the 2 groups they gave contingency management to showed greatly reduced stimulant use during treatment, although they developed a CBT protocol, that particularly for gay and bisexual men, and found that that actually drove down the high-risk sexual behavior more than the other interventions. It was a really interesting study. Medications, since you are psychiatrists and you may be interested in this, and this is, I think, Steve, well, Larissa Mooney helped me. Steve Shoptaw, Laura Ray, there's a bunch of folks at UCLA who have been involved in this work over the years. Walter Ling was involved. I went back and was looking at my CV. I looked, 1981, I published in the Archives of Internal Medicine a paper on imipramine, showing that it didn't work with meth users. So I think I have the land record for the oldest negative trial on methamphetamine. But these are some of the medications that we've looked at. UCLA was a hub for testing of methamphetamine medications for about 5 years. We ran all kinds of trials on all kinds of medications with all kinds of rationales, and mostly got negative effects. Now, I have to say, in retrospect, in looking back at the data, I think some of these trials, we were not measuring medication compliance very effectively. And I think some of our participants became professional study participants, and they would enroll in the study and come and do the data, but we didn't really know whether they were taking the medicine or not. So I think it's a limitation for this whole batch of negative results. Some of these things may actually work better than the study concluded. However, there are two medicines really that have right now the most promised. Bupropion is one that we've been involved with some of these studies. For those people who are less than daily meth users at admission, bupropion produced more end treatment abstinence than did placebo, significantly more. And if they were adherent to their medication, their end of treatment abstinence was much higher. So this is promising evidence for bupropion. The other one that is a leading candidate is mirtazapine. The group in San Francisco has done this work. They've now published their second randomized placebo-controlled trial, both showing with mirtazapine, they get a reduction in both the use of methamphetamine as well as HIV risk behaviors. As I said, though, some of the studies, we, in retrospect, look back at them and we think we probably should have done some things differently. And there may be some of these candidates. I still wonder about modafinil and its value. And I know there's some other new results that should be coming out shortly from one of the trials that was that Walter and Larissa and Steve Shoptaw have been involved with that may have some new information and more promising information. I do have to say, though, I've talked to a lot of docs who have used bupropion and modafinil with, I'm sorry, mirtazapine with individuals with meth use disorder. Nobody describes it the way they describe how an individual with opioid use disorder responds to buprenorphine. It's not, neither of these medications or any of the other ones that we've looked at so far has been a, wow, that has a strong effect. These are the best we have right now and the best information we have, but we're still, I think, a good way away from having an effective medication for individuals with meth use disorder. So methamphetamine being used in 2020 is more lethal than the earlier version, and meaning that we really need to get people into treatment and keep them in treatment to reduce their risk of overdose death. New research has shown better understanding some of the medical and psychiatric consequences. Behavioral treatments, particularly contingency management, have evidence of efficacy, and there are no medications with FDA approval for the treatment of meth use disorder. One last comment, as I've been working around the country, I do the presentation like this. I say contingency management is the, got all the robust evidence. People go, okay, well, we want to do contingency management. And then I say, except you can't do contingency management for populations on Medicaid because there's restrictions allowing giving incentives. So it's, right now we've got a real problem that this one tool we have, which is being used in the VA quite effectively, is not able to be used with most populations. And I will take questions, and thank you very much.
Now I'm unmuted. Great. I wasn't able to before. I will select some of the interesting questions that have come in for Dr. Rawson. One is there evidence that patients on buprenorphine for opioid use disorder who use stimulants are potentially protected from lethal doses of fentanyl, at least to some extent, which are added to their stimulants? Meaning, would being on medication treatment for opioid use disorder be protective if they do use fentanyl?
I think my best answer is I don't know. The issue of fentanyl and buprenorphine interactions is not 100% clear to me. That may be one more appropriately answered by an actual doctor. Larissa, if you want to, you know the answer.
I'm happy to chime in that fentanyl is more potent, so there's still a risk, but it is safer to be on medication treatment with any opioid exposure. So that would be the safest, is to keep them on their medication. Moving along. There's some really interesting ones, actually. You alluded to use of opioids in individuals with opioid use disorder being driven by negative reinforcement to avoid withdrawal, while stimulant use is driven more by positive reinforcement. Is there evidence that addition of fentanyl to stimulants could result in a more highly addictive compound driven by both positive and negative reinforcement? Are they using fentanyl-contaminated stimulants and potentially reporting more withdrawal effects, opioid withdrawal, than individuals who use stimulants before contamination by fentanyl became widespread?
That's a great question. And I have heard, and again, I didn't say this in my introductory comments. I'm sitting in Vermont right now and have moved back here since 2015. I am not out on the street interacting with individuals who use methamphetamine and fentanyl now. I don't know. I have heard from San Diego that some of their clinics, they're seeing individuals seeking treatment for methamphetamine dependence, but the major symptom they want to address is their opioid withdrawal. So they kind of view themselves as individuals who use methamphetamine, but the thing that's driving them into treatment is the opioid withdrawal. So I do think that it is from the cartel point of view, you're actually producing people who have, now you have them connected both ways with stimulants and with opioids. And I do think the opioid withdrawal driving dynamic becomes more potent over time and probably takes over.
Okay. There's several questions that I will combine about contingency management. Why does it work better? And is there evidence about digitally delivered contingency management, app delivered contingency management?
Yep. Yeah, I think that the case could be made that it's unique.
Can you define it?
Excuse me?
And can you define it?
Contingency management is, read B.F. Skinner, 1938, The Behavior of Organisms. It's the systematic use of positive reinforcement. It's providing, identifying behaviors that are clinically, therapeutically positive, like giving drug-free urine samples or attending treatment sessions or completing homework assignments, and providing them with a reinforcer, giving them a voucher, giving them some, they can earn stuff by their behavior. It seems to be particularly well suited to individuals with stimulant use disorder. The results, Steve Higgins from here in Vermont did the first study in 1991. They had to stop the first trial because the results were so overwhelmingly positive for contingency management. The amounts of money people use, or no, we never give money as a reinforcer. Money's a trigger for individuals with stimulant use disorder. But they can get things like grocery vouchers and you know, certificates for gasoline and all sorts of things. And over time, if you provide that structured reinforcement program, it can be extremely robust in reducing stimulant use, as long as it's being provided, of course. Like we have with our medications, like buprenorphine doesn't work after you stop giving the buprenorphine. With contingency management, you do get some recovery after you stop the reward. There are apps, there's a number of apps right now. Dynamic Care is one that I think has really got great promise, particularly with patients on buprenorphine in primary care where they don't have a whole behavioral health group wrapped around them. They could actually use the app to deliver reinforcers to people. Also, there's one called Reset from Pearl Pharma. So yeah, there are apps that are being used right now to deliver contingency management.
Okay, it looks like we have time for one more question. Do you have any tips on how to reduce fentanyl overdoses in this population, including programming? Per my understanding, utility of distributing fentanyl test strips to people who use meth is limited by false positives.
I do know here in Vermont, they were giving out fentanyl test strips 5 years ago. They no longer give them out because all the cocaine has fentanyl in it. And so testing it to prove what they already know is, I do think California, it's still not 100%. Test strips, I think, could be useful. Obviously, naloxone or Narcan can be useful. Giving individuals who use methamphetamine, routinely giving them Narcan to carry and instructing them about the fact. I mean, partially you need to educate the patients about what fentanyl is and how it's not the same as the heroin they used to mix together with their stimulant. That this is 100 times more potent. So patient education is important. Syringe availability and the other things I mentioned, but how to specifically reduce fentanyl overdose, nothing more than the kind of generic things I talked about.
Wonderful. We are almost at the top of the hour. Thank you, everyone. We didn't get to all of the questions.
People can send me emails.
Wonderful. Thank you for that offer. And same if it's a medication-specific question, I'm happy to field them if you want to email me as well. But thank you, everyone, for joining this exciting talk. And thank you, Dr. Rawson.
Thank you. Thank you, everybody. And thank you, Larissa.